Hey you guys, welcome to your lesson on vital signs and assessment of pediatric patients. So there is a ton of stuff that we could talk about on this topic, and your textbooks will go on and give you lots of lists and checklists and tables. But what I really want to do is tell you what I wish somebody had told me. So we will cover some of the basics, but what I really want you to take away from this is how to spot a sick kid. And I'm not talking about kids who have an ear infection or a cold. I'm talking about those kids that are deteriorating and need you to step in and do something. So let's get started. So first things first, kids are different. They respond differently to being sick, and because of this, we have to look for slightly different things when we're assessing them. So let's just start with a quick chat about their A and P. One of the first things you're going to notice is that kids have big heads compared to the rest of their body, and this impacts their airway, and it also makes them more prone to injury. Second, some of their organs are immature. So, for example, their lungs and kidneys don't actually reach full maturity until they're 2 years old. And this matters because it explains why something like a common cold that for you and I would just mean an annoying couple of days can actually knock a baby flat on their back and make them really unwell. Kids also have a larger body surface area, and this makes them more at risk for hypothermia and dehydration. Their increased metabolism impacts medication dosing and also sort of the way that we approach nutritional considerations. And as for growth and development, you already know that everything we do is 100% influenced by kids' ability to communicate and understand what's happening to them. And that's pretty much all you need to know for this lesson. We'll give more specifics on growth and development in those lessons. Let's talk about technique. So the things that we have listed here are very basic and straightforward, but I think they're worth mentioning because they're really going to help you out. So we talk all the time about making sure kids are happy and stress-free, but I want you guys to have less stress too, and these 4 things are probably the 4 tips that will make it the easiest for you when it comes to assessing. So first, be opportunistic. And all this means is that you're going to do your best to work around the kid. You're not necessarily going to be doing that head-to-toe assessment. You're going to have to abandon your checklist just a little bit. So, for example, if you walk into a room and you see a beautiful little baby and they're sleeping so quietly and beautifully, this is when you're going to listen to their heart and lung sounds, because this is when you're going to be able to hear everything. If you do it when they're unhappy or screaming and awake, it's going to be that much more difficult. On the other end of the spectrum, if you walk in the room and the same little guy is screaming his head off, you can also use that to your advantage. First, you know his airway's totally fine. And then you can take a second, look in his mouth. Does he have thrush? Are his mucous membranes moist? Is he teething? All those things you can figure out working around the kid. So before moving on to the next point, I do want to add a quick thing here. So I want you to be opportunistic, but I also want you to be thorough. And the reason I say this is because, yeah, we want kids to be happy. Yeah, we want them to sleep. But it's really important that you don't get in the habit of cutting corners to avoid upsetting them. Because if you do this, you will end up missing something really important. All right, so next thing to do to sort of ease things for you and the patient is to do the least invasive things first. You want to do the things that are not going to stress that child out and save the painful, irritating things to the end. And usually this just means ears, throats, nose, and genitals are going to be saved to the last. Third thing to do is involve your caregivers. There's almost always somebody in the room that can help you, and those people know the child. They know them super well, and they are going to be your best friend when it comes to getting that child to cooperate. And then the last thing here is just play. Use play, guys. It's so important. Use games and movies and superheroes and princesses to get the job done. Little tiny Hulks can show you how strong they are, and little princesses can walk and twirl and show you their coordination. Again, that's just one of the best parts of PEDS, so make sure you use that to your advantage. Okay, let's move on to talk about vital signs. For temperature and pulse ox, we're pretty much looking for the same range that you would be expecting in an adult. So 97.8 to 99.1 degrees Fahrenheit would be normal. And for our oxygenation, we're looking for 95 to 100%. Now, for pulse, respiratory rate, and blood pressure, there are different ranges to know for each age group. But one way to think about this is just to know the upper limit and kind of know what trend to look for. So for pulse and respiratory rate, you start out with quite high numbers. So an infant can have a pulse of up to 160. They can have a respiratory rate of 40 to 60. So both of those are quite high. And what you're going to look for over time as they age is those numbers are going to drop and become more adult-like. For blood pressure, it's the opposite. They start out with a really low blood pressure. So you can see an infant with a value of 80 over 60, and over time, that's going to increase to become more adult-like. So let's just cover a couple of points on technique before we move on. So number one, make sure when you take a temperature that you use the correct type of thermometer. One of the most important things to know is that children who are less than 4 and 5 years old can't really use an oral thermometer, so you're going to have to use something else. For checking a pulse, the major difference is to know that children who are less than 2 years old, you need to count an apical pulse for a full minute. And this is the most accurate way to do this. This is because irregularities are pretty common. And also, if you've ever tried to feel a pulse on a teeny tiny wrist, it's really difficult. It's rapid, they're tiny, and you're really likely to feel your own pulse instead. For respiratory rate, infants, again, they are irregular abdominal breathers. So to count their respiratory rate, you need to watch their little tummies. And again, you need to do that for a full minute to make sure you're getting an accurate rate because they can breathe irregularly. And this means that they may take a lot of really quick breaths and then they pause for a minute. And then they take a lot of really quick breaths and then they pause. So count for a full minute. For blood pressures, make sure that you use the right cuff size. And sometimes it's really helpful if you tell the kids that you're just going to give their arm a quick squeeze or a hug. I know that sounds kind of silly, but it does make it less scary for them. Regarding vital signs, make sure you take a look at the lesson outline and the cheat sheet that's attached to this lesson. You'll find that the correct vital signs for each age group are listed there, along with a lot of other important details, including some information about pain assessment in kids. So go have a look at that. Okay, guys, so we're moving on to sort of the meat of this lesson. And like I said at the beginning, this is not going to be taking you through a head-to-toe checklist. It's all about understanding what's happening when a kid deteriorates and then focusing on the assessment findings that you just absolutely can't miss. So when I was a new nurse, I just didn't really have a solid understanding of what I'm about to talk to you about. And on one of my first shifts as a peds nurse, I found myself taking care of a 3-month-old baby that was really, really, really sick. And you guys, I was not connecting the dots. I was waiting on this kid's blood pressure to drop. I was waiting on their oxygen levels to drop. And I wasn't picking up on the fact that things were getting worse. Thankfully, a senior nurse did step in and help me to see what was happening. And we ended up doing everything we needed to do to get that kid better. But I don't want you to find yourself in this situation. I want you to be able to know when your patient is getting worse. So the first thing to understand about really sick kids is that if a cardiac arrest does occur, it's usually the endpoint of a really long process. So what we're having kids who are sick for a long time, and then they're having this arrest. Usually the initial problem is respiratory. And when that arrest occurs, it's usually because of hypoxia and acidosis. This is different than a lot of our adult patients who present in cardiac arrest, because a lot of times they're walking around doing their thing and then they have an arrest. So you don't have this large amount of time where the kid's becoming more and more unstable. So what this means is that when a child does arrest, they are in such a bad state metabolically that a lot of our resuscitation efforts don't work. We don't have great outcomes if an arrest actually occurs in a child. And this is why it's so important for us to identify that deterioration long before we get to this endpoint here. So like I mentioned in my own personal example, hypotension and hypoxia are really late signs, and you can't wait for those two things to happen to intervene. So what we're going to do next is just look and talk about what are the things that we need to know so that we can make sure to intervene before it's too late. All right, the assessment triangle that you see here is probably most often used in emergency settings, but it gives us a good structure and you can apply it to any environment. Because if a kid is struggling to breathe, if they're post-op and you're worried about them, if they're becoming septic, all of those situations are emergencies, so you can use it anywhere you are. So let's just start with A. So A is our airway and appearance assessment. Remember, our really little kids can't tell us how they're feeling. They can't tell us that their chest is getting tight. So we have to pay extra close attention to their behavior. And basically, the major takeaway here is that the scariest presentations are the quiet ones, okay? We want our kids responding. If you're poking and prodding a child and they're just laying there quietly, alarm bells should be going off. If you're taking care of an adolescent patient with asthma and they can't talk because they're having such a hard time breathing, again, alarm bells. We want our peds patients a little bit upset and pushing against us. If they aren't, we need to know why. Other red flags that you need to pay attention to for airway and appearance are stridor, drooling, lethargy, poor tone. All right, so let's talk about B. So B is breathing, and what you'll hear us talk about a lot in pediatrics is work of breathing. And all this means is how much effort a child is having to put in to moving air in and out. We know a kid is working really hard when we see nasal flaring, retractions, grunting, and an increased respiratory rate. And I want to highlight tachypnea as a really important finding because it's kind of a tricky one. So they may have an increased respiratory rate, but everything else looks pretty normal. A lot of times this increase in respiratory rate is your first sign that something is wrong. Remember, earlier we said their lungs are immature until about 2 years. Well, when they're sick, it's much easier for a kid to breathe faster than it is for them to breathe more deeply to compensate. So pay close attention if you see that respiratory rate creeping up. All right, so C stands for our circulation assessment. And for this part, you've got to get your hands on your patients. We need to be feeling their arms and their legs. Are they cold, cool, clammy? And the next most important thing is probably checking that capillary refill. And you should be checking this almost first thing on every single patient that you see. We expect capillary refill to be less than 2 seconds. And if it's anything longer than that, something's wrong with their perfusion. And this is when we start to treat, not waiting until you get that low blood pressure reading. So all of these red flags, plus a couple of more, are listed in the outline. And if you feel like you need some context or a refresher on what some of these symptoms actually look like, we've got some really awesome videos in the resources that will help you with that. Okay, guys, your priority nursing concepts for pediatric assessments are clinical judgment, prioritization, and oxygenation. I really, really hope you guys found this lesson helpful. Like I said, it's based on my own experience that I highlight all of this, and it is all 100% foundation for your work with kids. If I could only have you listen to one lecture during your pediatric course, I would definitely want it to be this one. So your key learning points to take away are that kids are different, and this means that you do have to use different skills and know what to look for. Number 2, be opportunistic, but be thorough. Number 3, early detection is so important if we're going to have good outcomes. So remember, hypoxia and hypotension are late signs. Know your ABCs. That's a great structure for making sure that you don't miss out on those red flags. And then finally, commit those red flags to memory. Don't ignore them, even if your patient doesn't look that bad. Remember, the goal is to keep them from ever getting to that point so that we can have the best outcomes. That's it for our lesson on vitals and assessment. Again, make sure you check out all those really awesome resources that are attached to this lesson. Now go out and be your best self today, and happy nursing.